Dear viewers, welcome you all to our show OSA, that is Orthopaedic Solution Academy. Hope you all are well with your friends, family, and your patients. Dear viewers, today our topic is the future of the joints of the ankle and foot by Ilizarov. And the speaker is the one and only, the legendary Ilizarov surgeon of Bangladesh, Professor Mofakhkharul Bari, sir. I would like to request Professor Mofakhkharul Bari, sir, to join with us. Good afternoon, sir.
Good afternoon, everyone. Good afternoon. Okay.
Thank you. Thank you very much, sir, for joining with us. Dear viewers, we have learned academic experts with us. One of them is Professor Novikov, sir, the highly academician from Kurgan, Russia. I would like to request Professor Novikov, sir, to join with us.
Good afternoon, everybody. Good afternoon, colleagues.
Good afternoon, sir. Thank you very much for joining with us. Dear viewers, we have another learned academic expert from Kurdistan, Iraq. That is Professor Omer Barawi, sir. I would like to request Professor Omer Barawi, sir, to join with us.
Good afternoon, everyone. Thank you so much. Good afternoon.
Good afternoon, sir. Thank you very much for joining with us. Dear viewers, we have another enthusiastic Ilizarov surgeon from Patna, India. That is Dr. Shamsul Huda, sir. I would like to request Dr. Shamsul Huda, sir, to join with us. Good afternoon, sir. Dr. Shamsul Huda, sir, good afternoon. Thank you very much, sir, for joining with us. Thank you very much. Dear viewers, we all know that the foot and ankle is a challenging part for all orthopedic surgeons. But in case of fusion of the joints of ankle and joint, we have different methods. But how we can do it by the magical Ilizarov, that will be discussed today. And the presenter is the magnificent presenter, Professor Mofakhkharul Bari, sir. I would like to request Professor Mofakhkharul Bari, sir, to share his screen and start his presentation. Sir, would you please share your screen, sir, please?
Okay. Can you see my screen? My screen is
sir,
visible or not?
Yes, sir. It is absolutely visible and you are perfectly audible, sir.
Okay. This is as usual, that I'm showing. These are the centers, all these things. And so let us talk on today the fusion of the foot. There are lots of joints in the ankle. If you look at the anatomy of the foot, you can see how many bones and how many joints are here. Just for your, you know all these things, just I'm showing the anatomy of the foot. Now, regarding the bones and joints, mobile joints of the foot and ankle, essential joints are ankle joint, that is we are telling them the tibiofibular joint, subtalar joint, tenonavicular joint, and metatarsophalangeal joint. Joint that move a moderate amount, that is calcaneal cuboid joint, cuboid metatarsal joint for the fourth and fifth metatarsal, and proximal interphalangeal joint and distal interphalangeal joint. Now, joint with minimal movement, you can see non-essential joints are navicular cuneiform, intercuneiform joints, tarsometatarsal joint, that is we are calling Lisfranc joint, and bones of the lower leg and the hind feet, tibia, fibula, chalus, calcaneus. All these things you know, just I'm telling you so that you can have a small look. You can remember or recapitulate all these things. Joints of the hind foot, ankle, tibial, and subtalar joint. So now, tibia and fibula, we know these are the two long bones. Just look at this one. This is interosseous membrane, and this is anterior inferior tibial ligament. And look at the talus, position of the talus. And this is the ankle mortise, medial malleolus, and lateral malleolus. So this is the overall ankle joint you can see. And then if you look at this, talus is the top most proximal bone of the foot, because it articulates with so many other bones. 70% of the talus is covered with hyaline cartilage. See from the lateral side, these are the beauty of the talus and the subtalar joint here. And if you just calculate here, This is the body of the talus, neck of the talus, and her head of the talus. So next one you can see regarding the calcaneus, which is playing a very important role in the foot, and along with the talus, it makes up the area of the foot known as the hind foot. Calcaneal anatomy, you just look at this here, and subtalar joint. This is very important joint because when we need to do a arthrodesis, we must have clear idea regarding the anterior facet, middle facet, and the posterior facet. And at the same time, you see the calcaneo-kyphoid joint, the position of that. So this is the overall structure from the lateral view of the ankle joint. Now, bones of the midfoot. What are the bones? Kyphoid, navicular, and cuneiform bones. Now look at the AP view. You can see here the position of all the bones, how they are interrelated with each other. Lateral cuneiform, medial cuneiform, and the medial cuneiform and middle cuneiform. At the same time, the tarso-metatarsal joint, which plays a very important role, we call it the Lisfranc joint. So, metatarsals, each foot contains 5 metatarsals, numbered 1 to 5 medial, grade 2 to lateral. The first 3 metatarsals medially are more rigidly held in place than the lateral 2. And the metatarsals articulate the midfoot at their base, a joint called the tarso-metatarsal joint. Now, look at these, the phalanges. We must keep in mind that the position of the IP joint of the great toe, first toe known as the great toe, or we can tell it the hallux, is the only one to have 2 phalanges. The other lesser toes have 3. So difference that here is the 2, other has the 3. So the sesamoid bones also plays important role in the foot. 2 sesamoid bones located directly underneath the first metatarsal head, embedded in the medial tibial side and the lateral fibular aspect of the flexor hallucis brevis tendon. So if you think about the foot of the joints of the foot, then you should have to know how you can go for fusion of the foot. So fusion of the foot, that means arthrodesis of the foot. This is a permanent joining or stiffening between the arthritic bones of the foot. The bones are held together with Ilizarov that act to stabilize the bones tightly together while your body naturally allows the bones to combine and fuse together. What is the foot arthrodesis? Very simple. It's a surgical technique consisting of the artificial fusion of the bones forming the joint which become immobile after the surgery. So now foot arthrodesis is done. What is our goal of intervention? Is to relieve pain or to reduce any deformity caused by poorly healed fractures. In case of rheumatoid arthritis, osteoarthrosis or arthritis, infections, and congenital defects. Now, if you think about the fusion of the joints of the foot, you should have to go for the fusion of the ankle joint. Fusion of the, and of course, so now look at this fusion of the ankle joint. Ankle arthrodesis is the fusion of the subtalar joint, most commonly performed for end-stage arthritis of the joint. This procedure may be performed with an open approach or arthroscopically. The most common complications are developed of subtalar arthritis and non-union. Now, here you can see the right side, the X-ray. If you look at this, see the mortise view, mortise and ankle mortise. See here the degeneration of the lateral side and talar sheath to the lateral side, and degenerative and dystrophic changes of the whole ankle joint. Now, subtalar fusion is below the ankle joint and allows side-to-side or tilt movements of the heel. The purpose of subtalar fusion or arthrodesis surgery is to remove the painful arthritic subtalar joint surfaces and fix them together with the aim that the bone will grow across and fuse the joint and will get good arthrodesis. Fusion of the ankle and subtalar joint. In double joint fusion, the configuration is similar to that recommendation for fusion of the ankle joint. Now, regarding the triple joint fusion or triple arthrodesis is a versatile procedure useful in many pedal conditions and gait disturbances. The term triple arthrodesis refers to fusion procedure of the three joints of the hind foot, the subtalar joint, that means talus and calcaneum plays a very important role, the talonavicular joint and the calcaneo-keyboard joint. These all are the joints which related to the triple arthrodesis of the ankle. Now, foot arthrodesis, when we are using the Ilizarov technique, it provides high union rate with the added benefits of early weight bearing. We can get unique advantage of its ability to promote regeneration of the soft tissue. This is very important. And soft tissue regeneration around the ankle joint, which means dermatogenesis, myogenesis, neurovascular genesis, and its versatility to allow correction of the position of the foot by adjusting the frame post-operatively as needed. We can do it by Ilizarov technique. The use of the Ilizarov external fixator provides a successful salvage method that offers solid bony fusion, optimal alignment, eradication of infection in the complex ankle pathology, and failed previous all kinds of arthrodesis. Now, I would like to share my cases, dear friends. You can see here 2 months old dislocation of the right foot of a 29 years old male. So this is the situation you can see here, Lisfranc joint. Here is the fracture and dislocation. Now what I have done, so 2 months old, if you go for the open surgery, it creates a difficult. Initially, it was very difficult for me to go for this kind of reduction. Then this is the half ring with olive from this side, and this is another ring. Here you can see here. Then we have gradually pulled it, and this is the radiographic view, and you can see after correction, arthrodesis, before treatment, just you compare with this and this. See here, so the space, and this is after final treatment of the patient's foot. Case 2, you can see post-traumatic, post-operative right ankle varus deformity with subtalar osteoarthrosis. Look at this. He was treated elsewhere, and see the navicular bone with the talus. Here is the dislocation and overall joint, pathology here you can see here. Lateral view, you see this ankle position is more or less okay. The patient, while he was walking, he was complaining all the time with pain. Now look at this subtalar joint damage, degeneration of the subtalar joint. And then patient came to me, what I have done, I have denuded the surfaces of the talus and the lower part of the tibia, and then I have put the Ilizarov ring fixator. This is the distal, proximal, and the half ring here, and then this is with the half ring here. And gradually we have pulled that one, and what we have done, see radiographic view of the right ankle after correction. Look at this here, the position of the subtalar joint. We have done the arthrodesis, and you can compare. This is the before. Here you just compare this one and see this one. This is after 4 months only treatment. So these all kinds of biocompatible thin weights gives you very good stable fixation, and you can get good results. This is the case of 6 years old girl, post-traumatic right ankle and foot deformity with fixed equinus, no heel pad, very bad scar. Look at this here, standing, lying, and back view of the patient. These are the 3 positions you can see. And look at the bones of the Lisfranc joint, you can see here, and deformity and clawing of the toes. And what you can do here, and you can see the X-ray, dear friends, the talus, and the calcaneum, and the joint of the subtalar joint, and the equinus position of the whole foot. So what to do? These are the cases that is challenging for the orthopedic surgeon and for the patient also. So I can tell you this, what I've done with the Ilizarov fixator, gradual control coordinated stretching which hinges, and we have corrected the deformity, and this is with the Ilizarov fixator during correction of the deformity of the ankle and the foot. Now you can see from this situation to that situation, dear friends, and the condition of the skin, you can see the redness, vascularity increased, and this is the final view. You can see the calcaneum, subtalar joint, just compare from here to here, the skin condition, the clinical appearance of the ankle and the foot. So another case, you can see old Lisfranc joint dislocation. This is, look at this, see the navicular bone, this is the talus, and disorganized full Lisfranc joint. Now, again, what we have done, see, look at this, put one ring here, and this is in the calcaneum and the forefoot, and radiographic view, and you can see here after correction of the joint. So this is the external view of the patient only after 4 months. So the final result, you can compare from this situation to that situation. Patient is happy, and this is the result. Now you can see here chronic osteomyelitis of the left calcaneum, which is damaging the subtalar joint here. See talus and calcaneum. These are the problematic cases, and quality of the bone is not good. And this is a discharging sinus all the time. So you can do something, or you can do a very good surgery by Ilizarov technique, by which you can control at the same time infection, and you can arthrodize the subtalar joint. See, one ring here, and then by putting the half ring in the backside of the calcaneum, and with hinges in the half ring, and this is after removal of the fixator. And this is the, you can see here, the condition of the calcaneum here. See the black spots. There was a circulation hampered at that time. Now you can see the whitish position of the bones. It indicates that the infection already controlled, and the subtalar joint is fused by Ilizarov technique. So another case, you can see, dear friends, very bad case, right ankle varus deformity. You can see here the X-ray, and he was treated elsewhere, and patient was working with this kind of, deformity. And see here the bones here. This is the subtalar joint, and tarso-metatarsal joint, and at the same time, calcaneocuboid and talocancilionavicular bones, that is the Stropart joint, is also damaged here. So, again, what we have done the fix this continuous, 2 rings in the distal tibia, and then we have opened up a little bit, and then clean up these, and this is fixed to the hinges. And then look at this, after the removal of the apparatus, look at the back side, front side, and you see the varus position is already restored, and this is the view how he was walking before surgery, and this is the after surgery, only the follow-up of 4 months. Now, another case, post-traumatic deformity of right foot. Look at the foot and ankle, disorganized, whole tarsal bones and metatarsal bones. You can see here the quality of the bone osteoporotic, and patient was sitting like that. Look at the grade 2 and other toes and the deformity of the foot, and the skin condition is not that good. Then if you have Ilizarov and you have principle and technique, you can have a very good result with this Ilizarov technique. Look what we have done. So 2 rings here, and this is disorganized toes and phalanges by putting the multiple K wires here, and this is the external view you can see here, and this is, you can see, dear friends, the situation of that. This is AP view, this is lateral view. Compare this one with this, and AP view you can see, and more or less bone quality is good. The anatomy and the biomechanics of the foot and the ankle is almost restored, and it took 6 months to treat this patient. Now, from that situation, he was coming to my place with this situation by, this is the position of the foot, and now you can see the patient is happy. He's in a standing condition. The geometry of the foot is almost normal. Now, I would like to share my one very bitter experience with this case. You just minutely see the dear friends. This is a old fracture of the neck of the 2nd, 3rd, and 4th metatarsal. Look at this. Look at this. See the 3rd one fracture here, and it is damaged to that condition. See just the 2nd, 3rd, 2nd, 3rd, and the 4th. Only you'll see the last one is the OK. So this is a very late case, and the foot was a hallux valgus. See the position of the great toe, position of the great toe. This is hallux valgus. You can see here, and what we have done. Think for that. I have opened up. Just you see, we have done the osteotomy here to correct the hallux valgus, and this bone, almost all the fractures disorganized of the metatarsal and phalangeal bones was restored in the normal position. This is a very small bow, half ring here, and see the toes was corrected beautifully. Now I'm showing you the case. Look at this. This disorganized 2nd toe came here, 3rd one here, and 4th one you can see here. All disorganized bones. Here you can see this is the grade 2 hallux valgus. Now, hallux valgus is restored. Ilizarov thin wires. And this is another case. I would like to share my experience with this. Suffering with a old fracture of the ankle joint that you can see, and subtalar joint is what I have done. I have opened up, see beautifully corrected, denuded the subtalar joint, and we have put this one through the olive and half ring here. This position, and finally you can see, dear friends, the position of the talus subtalar joint. Now you see arthrodesis. So pain-free ankle, doing arthrodesis of the subtalar joint. And finally, probably, I would like to share one case, dear friends. That is Charcot arthroneuropathy of midfoot tarsal joint. You can see here, patient came to a place with the rocker bottom foot. Here was a big ulcer and his skin condition was blackish. And you look at the joint here. These are the difficult cases that you should have to face in your life. So you can see the talar. This is navicular was out. Navicular was out from the joint, navicular-cuboid joint and other joints also. And this is a preview you can see, dear friends. And what happened? I have done the, color Doppler. You can see here, this color Doppler indicates posterior popliteal artery 65-70% damage, flow reduction, anterior tibial artery, posterior tibial artery, a deep dorsalis artery 70% reduction with the damage of the all bones. Now what to do? This is a color Doppler, and what I have done. This is very important that I'd like to share. See, I have taken the lecture regarding the diabetic foot and other talks with TTT. You can see I've done the transverse tibial technique, because when I have done here is the atherosclerosis, flow reduction. I've shown you the 4 vessels. Now see TTT here, and this is the fusion of this joint and TTT here at the same time. What happened then? Look at this. I have arthrodesed the subtalar joint, and the transverse technique, widening of the bone. Patient came to me 2 days back, and he told me he was too much happy without pain-free. He could not sleep even that before surgery. Now you can compare the X-ray of here, X-ray of here, radiograph, and this is the view of the here, and this is the widening. So limb length discrepancy and other things by Ilizarov. So this is the arthrodesis that I am showing, widening of the tibia. While you are doing that, you will get a very good new vascularization in the whole limb. So this is AP view. This is the lateral view. Patient is happy. Before that, you can see here, the ulcer, black skin, everything is gone. And these are all things that, has biological prediction. These things, because a single technique with biocompatible thin weights, you can get limb length discrepancy, any kind of bony and joint deformities that I shared you. You can have a soft tissue contractures correction. Hopefully, you can control the infection, transverse destruction that I've shown you, and you can treat any kinds of ischemic links. These are all the Ilizarov why we are using. And finally, always that I show to you that on the basis of evidence that I've shown you. And this evidence is always based on science, and at the same time, of course, the surgical skill of the patient. So these are the things that I could share you with these are all my stalwarts of Ilizarov in 2019 in my center. These are the books publication and everything that we got due to this gentle, benevolent, excellent, and scientist Gabriel Abramovich Ilizarov. Thank you so much for your kind attention, dear friends.
Thank you very much, sir, for an awesome presentation. Now, I would like to request our honorable academic expert to share their knowledge. first of all, I would like to request Professor Novikov sir to share his knowledge. Professor Novikov sir, can you hear me, sir? Please.
Bari, I want to say thank you very much for your skills. In our center, we have 22 different departments with different specialization. We have special department for foot. We have special department for hand. We have special department for hip joint, for deformity correction, for trauma case. And if this is infection situation, we have infection clinic. And so many cases show Dr. Bari, and all of these cases in one hand. Only one question: how he can and find time for support. Like doctor, I am very satisfied because all of these cases very difficult. And Dr. Bari, usually your patients stay in the hospital, or you continued correction when patient leave from your clinic. Job period of frame.
Yes.
Where stayed patient? Because result is perfect. Who make?
Yes.
Doctor or patient?
Yeah. Yes, a very good question, because these are the cases that I have shown to you, very difficult cases. If you continuously follow the procedure that you have done, if you instruct your patient, then you will have a very good result. That's why I always tell my patient with all these difficult cases, you must spend minimum 3 to 4 weeks, that is 1 month in my hospital. I have done the cases, I don't release them. I don't release them because before doing the surgery, I must counsel the patient. As for example, for the diabetic patient, what I have shown you, the one case, only one case I have shown you. I am doing a lot of cases every week. The transverse tibial technique, when we are doing, we do the longitudinal osteotomy, and after 10 days, we started for distraction here because this is the cortical bone, not metaphyseal bone. That's why you should have to for 10 days. 10 days initially, then I tell them to the patient to go for distraction for 3 to 4 weeks. So minimum patient, when distraction is finished, then I tell them to leave the patient, leave the hospital, then come to my place after 1 month, or depending on the situation where he is living. If far away in village, then I tell them always counseling is the very important to check the apparatus, everything. Then you will have a very good outcome. Otherwise, no. Before doing surgery, Ilizarov surgery starts after doing the surgery, not that we are doing interlocking or plating, finish. No. So you must tell them they should have to come, you should have to follow the apparatus, tight, not everything, all wires, all nuts and bolts. This is very important. Otherwise, you cannot expect a very good outcome. So this is probably you are satisfied with my question, with my answer.
Thank you very much. Thank you. And I am happy all of result difficult, and you support patient with perfect Ilizarov results, Bari Ilizarov result. Thank you.
Thank you very much, sir, for your nice questions. Now, I would like to request Professor Omer Barawi, sir, to share his knowledge regarding the presentation, sir. Sir, you have to unmute yourself. We can't hear you, sir.
Are you hear me? Okay.
Yes,
Thank you
sir.
so much. Thank you so much. Really, they are very interesting and difficult cases. I totally agree that Ilizarov method is not only in the procedure and planning. Much more important than this is follow-up. So it is not so easy to do proper follow-up from every aspect, psychologically, familiarly, and economically. In spite of that, he did very perfect results.
Yes.
Thank you so much. Thank you.
Right.
Thank you very much, sir. Now, I would like to request Dr. Shamsul Huda, sir, to share his knowledge regarding the presentation. Dr. Shamsul Huda, sir, please.
Thank you, Dr. Tanvir. Thanks, Bari sir, for such a wonderful lectures. We have been using different modalities for ankle orthodesis like wires, screws, and treated nails. But Ilizarov, they cannot be applied in all the cases. So Ilizarov becomes a very good method for ankle orthodesis. I have one question for Bari sir. For in the Ilizarov cases, do you open up the subtalar joints and the tibetalar joints to denude the cartilage, or do you just give compression with Ilizarov, sir? Bari sir. Novikov sir.
Bari sir, can you hear me, sir? Bari sir, can you hear me, sir?
Sir, did you get
now
the
I
question?
can hear you. Is there any question to me?
Sir, yes, sir. There's a question for you, sir. Sir, in the ankle orthodesis cases with Ilizarov, do you open up the tibetalar joint and subtalar joint to denude the cartilage, or you just give compression, sir?
No, I could not listen again. Ankle orthodesis, what?
Sir,
Sir, do you
in case,
yeah, please, Dr. Tanvir, please repeat.
yes, sir, please. With kind permission of the Dr. Shamsul Huda, sir, I would like to repeat the question, sir. Do you denude the cartilage? Do you denude the cartilage before
Yes.
fusion, sir, or
Whenever-
orthodesis?
All cases you must denude. You just open and denude the cartilage, then you can fix. If your bones are osteoporotic with biocompatible thin wires and olive wires, is very easy to compress orthodesis. You must denude. Without denude, you cannot have a good orthodesis. This is non-diabetic patients. For diabetic also, but for diabetic patient, you'll get orthodesis that is called not bony. We have two orthodesis. One is bony ankylosis and a fibrous ankylosis. In case of diabetic foot, you will get the fibrous ankylosis because the bone is not good. Most of the cases like that. A non-diabetic patient, you will get the bony orthodesis, bony fusion, because bone quality is good. So whatever orthodesis you do, fusion you do, you have to go for fixation, fusion.
Right. So my
Okay.
second question is, yes, sir. My second question is, what is the protocol of keeping the rings after orthodesis? How long do you keep in post-traumatic cases? What is the duration of the ring, sir? Dr. Tanvir,
It
can you
depends
repeat?
on your case. If you do for ankle, 2 to 3 months, you will have a very good results. Maximum 3 months.
Yes, sir. So-
Sir, I have one question, sir. Thank you.
Maximum 3
Yeah,
months
please,
you will
please.
get.
I have one more.
Triple
Yeah. And do you apply brace, sir, after that?
Bari sir, can you hear me, sir?
Sir,
Now
you
I
hear, sir?
can hear.
Sir, after removing the rings, do you apply brace or just allow the patient to walk freely? In these
After
cases,
removal
yeah.
of the ring,
Yes, sir.
you go for fixation of the plaster, few days for plaster, for 3 weeks plaster, and then after 3 or 4 weeks you remove the plaster, and accordingly you do the physiotherapy. It's good.
So no bracing, sir. Right,
As
sir.
soon as you remove,
Sir,
you must put the plaster for few weeks.
Sir, what is the special directions, protocols in the shocked foot, sir? The shocked foot, because there are difficult cases.
Huh?
Sir,
what
can
is
you
What is
special
the
protocol
what?
for shocked foot, sir? Shocked foot, sir. What is the special recommendation and protocol? Because these are difficult cases.
Shamsul Huda,
Dr.
Sir,
can you repeat?
yeah. Sir, can you catch the question, sir? I think there is a network problem, sir. Would you please repeat the question,
No,
Dr.
you
Shamsul Huda, sir,
repeat
please?
the question
Sir,
because
what is
this is not
your special
this is not
protocol in
audible.
shocked food, sir? In the shocked food, the special protocol, because they are difficult cases.
Charcot food.
Yes, sir.
Yes, a special protocol. See, for any charcot food, can you hear me? You must do
Yes.
the color Doppler first. See, color Doppler. Special. Whenever I go for any kind of charcot in the ankle, charcot in the calcaneum, charcot in the midfoot, less Lisfranc foot, I must do the color Doppler first. You see, atherosclerosis is obviously in all the patients. Then, depending upon your case, you go for ankle or Lisfranc joint arthrodesis fusion, and at the same time you do the TTT, tibial transverse technique, that is to increase the circulation. In your atherosclerotic patient, you will see the flow reduction 60 to 70%. If you don't go for TTD, new vascularization, you will not get good result. Combination of arthrodesis with TTT gives very good result. Okay, follow me.
Yes, sir. Yes, sir. Thank you very much,
Tanvir?
sir. Sir, yes, sir.
Okay.
So I have one question, sir. Last one question from myself. There is in case of avian of talus, what is the procedure? What we can do by Ilizarov, sir? Avian of talus.
Yesterday, yes, tell us. Yesterday, I did one case of a lady, 61 years. Yesterday, a vein of the talus, you go for, listen to me. You go for subtalar joint fusion, because your circulation of the talus is not good. And at the same time, you just do a lower end of the tibia drilling, metaphyseal region, which I learned it from the Professor Shepsov. If you go for drilling of the lower end of the tibia, just above the ankle joint, drilling of the metaphyseal region, it gives circulation in the whole region. And I go for fusion of the tibio subtalar joint, that is talus and calcaneum. If your ankle is okay, and you go for a little bit distraction for 10 days maximum with
I think there is a network problem there. A very important discussion is going on. We are missing that. Bari sir, can you hear me, sir? We can't hear you properly, sir. Okay, I think.
Really, you understand me?
Sir, the last part we can't hear you, sir.
Follow me.
The drilling of the
No.
From the lower part of the tibia drilling, from that part we can't hear you, sir.
Metaphyseal region drilling, it increases circulation. Circulation in the ankle joint. Metaphyseal drilling. Then go for arthrodesis of the talus and the calcaneum fusion and distraction of the ankle joint.
Okay.
ASD, articulated hinge distraction of the ankle joint, which increases circulation in the ankle. Research was done in Kurgan. I do that. You understand me?
Yes, sir. We understand. So
Okay.
when we start the distraction of the ankle joint, just after operation on day 1 or after some days.
Distraction because when you are doing arthrodesis of the subtalar joint, you can wait 4 or 5 days, then you go for distraction for 10 days. 10 days.
Thank you very much, sir.
Somebody is doing 5 days. Even I have done the 10 days means 10 millimeter, 1 centimeter. It doesn't create distraction angiogenesis of the ankle joint. Articulated hinge distraction, that is called AHD, articulated hinge distraction. It increases synovial circulation, increases the ankle joint circulation, and relieves the pain of the patient. So, and metaphyseal drilling. You can have a publication written by Professor Shamsul. Just write down the metaphyseal drilling of the distal tibia in the foot or tibial technique. When my paper was wire technique, I showed you in that lecture. I've shown you these two, in the proximal tibia and distal tibia. You can go for drilling, and wire technique means consolo area going and just the cavity and the portion of the console wires.
Oh, Dr. Shamsul Huda, sir, what do you think about these console wires?
Console wire has a very important role in all these cases. It's very important because there is any less vascularization. Although I'm not on most cases, but when there is less vascularization, console wire really helps getting the circulations on here. So it is a very good role and it's a very good discovery.
I tell you, console wire is playing a very good role. In Kurgan Center, Professor Klushin, only one piece in the world, who is the head of the osteomyelitis center. He is using a lot of console wires to increase circulation and to minimize the infection in osteomyelitic cases.
That's great, sir. That's great.
And if you do the consular technique, but
we're facing lots of network problems, sir. Your voice has been jammed, sir.
Discoloration of the skin nicely improves.
Sir, Professor Bari, sir, can you hear me, sir, properly, sir, now?
Sir's network is interrupted, I think.
Yeah, I think.
Can we have view of Novikov, sir, about console wires?
Yeah. Novikov, sir, can you hear me, sir? Novikov, sir, can you tell us about the console wires, the uses of console wires? How do we use these console wires in case of osteomyelitis or to increase the circulations?
No, first part of your questions. I am a surgeon who used console wire more than 35 years. In our center, I was first. But sorry, I haven't cases with osteomyelitis. And in our center, this is technique now only start. We use because console wire is very good helper. Sometimes we cannot. This is depend of situation with condition of soft tissue, and console wire we can dislocate. This is excellent treatment, excellent methods when we can add to the difficult damaged soft tissue area some effect of Ilizarov with console wire. Sometimes console wire for me more effective than full K wire. And I am very often, each my patient, I use, doesn't matter with osteomyelitis, without osteomyelitis, for lengthening. Just now I talk with you and check all of patients. Today I have so many x-rays, and all of these patients with lengthening of humerus, this is guy, we use minimum 2 console wire. Humerus, tibia, all of segment, any patient, we use console wire.
Oh, that is great, sir. That is a great information for us. Bari sir, I have one last question about the chronic osteomyelitis of ankle joints. Can we use the destruction method in case of chronic osteomyelitis in case of ankle joints, sir?
Ankle joint, if it is damaged, ankle joint means lower under the tibia and the talus, calcaneum, all are damaged, then you should have to clean everything, then you can go for fusion.
No, sir. In case of
you can use
sir.
Ilizarov compression osteogenesis, destruction osteogenesis. This is the beauty of Ilizarov.
You have told, sir, just you have told that in case of if we give
you can go for fusion.
Yeah. No, sir. If we don't go for fusion, sir.
No other alternative way. No.
So for the ankle joint orthosis, sir, regarding distraction, are we using distraction in all the cases or few selected cases, sir? Bari, sir.
Sorry?
Sir, for ankle arthrodesis, regarding distraction, after compression, distraction is being done by you in all the cases or selected cases only?
Selective cases also. Selective cases.
Sir, indication, special indications, can you enumerate?
And
indications for distraction.
now, some difficult cases. That's impossible. During my long experience working with Ilizarov, I must tell you, the technique is so nice. Technique is nice. That's why I love this technique. And outcome is so good. Those who are related to the Ilizarov technique, only they can understand. Only they can understand. And you see, I'm telling you the truth. Most of the orthopedic surgeons in my country, now they are doing, young generation, they are doing Ilizarov, but devotion, dedication, honesty, and Ilizarov, I told all the time, it must be like your wife. You must have your wife. You love your wife. You love your wife. You must love Ilizarov. Otherwise not, you have done the technique, you don't check the patient, no. Proper wear tension, ring size, proper stability, these are the important things, and you will have a very good outcome. I'm telling you one case. Day before yesterday, I have seen one patient with Ilizarov in the tibia for 2 years. Can
the network is Not clear, sir. Sir, we cannot hear you properly, sir. The
2
network
years.
is... Okay, I think we will got the answer in the coming part of the program. As because of the network problem, we can't hear Professor Bari sir clearly. And that is the end of our program today. Before ending the program, I'd like to thank Raj TV and Marius ENT Specialist Hospital for sponsoring our program, and definitely all of our academic experts and the honorable speakers. Hope we will connect with you in the coming Friday with another magical Ilizarov topic. Till then, I'm Dr. Tanvir Ashraf saying bye-bye to all of you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our